Welcome, man. Welcome.
हाँ आ रहा हूँ
Silence, please.
Hello everyone.
Silence.
Welcome to pre-Diwali CME program. Today we will be having two lectures in collaboration with and mind.
YouTube live है.
One lecture is by
आपको देता
Dr.
हूँ लिंक
Vani
बाद में.
Kulhali and another one is by Dr. Jayesh Shardhara. I am sure that both the lectures are going to be the educational treat to all of us. I hereby wish everyone a very happy Diwali and prosperous New Year in advance.
Can you put it? YouTube live है. ये YouTube live है.
तो काय is a renowned neurospine surgeon in Mulund who specializes in minimally invasive brain and spine endoscopic surgery. Dr. Jayesh Shardhara brings over 15 years of expertise in minimally invasive endoscopic cranial and spine surgery to SL Raheja Hospital and Fortis Hospital, Mulund. Dr. Shardhara completed his MBBS from Saurashtra University, Gujarat, and an MS General Surgery from the same institute. After completing his neurosurgery, he obtained a professorship in the Department of Neurosurgery from Lucknow and gained abundant experience in advanced brain and spine surgery. Dr. Shardhara has extensive training and experience in the utilization of minimal invasive spine surgery techniques, having been trained in some of the best spine surgery centers in the world from Japan, Seoul, South Korea. Dr. Shardhara has been trained in epilepsy surgery at the Sri Chitra Institute, Kerala. He was awarded with the Best Young Neurosurgeon India Award in 2016 in Mumbai. He is the current editor of Journal of the Spinal Surgery and has patent in his name. He has done 1,000 brain surgery and 1,800 spine surgery. And there are 120 publications in his name. To Dr. Shardhara. Come. आगे का लाइट कम कर दो.
Thank you. Good afternoon to all. First of all, thank you, ma'am, for this generous introduction. And I'm really grateful to Mahim Dharavi Medical Practitioner Association, respected Dr. Jain, Dr. Vijay, my Raheja team. Thank you for this opportunity. When I come here after delicious lunch, first of all, thank you for that. And I came to know that I am amongst Mumbai's very known celebrities, and I also got excited for that. And today I'm going to present you the glimpse of advanced neuro and spine surgery. The objective is very simple. सबको ऐसा है कि ब्रेन एंड स्पाइन सर्जरी नहीं करनी है. अभी तक हमारे माइंड में वही मिथ है. So in next 20 to 25 minutes, I will hit that myth कि क्यों करनी चाहिए, क्या एडवांटेज हो सकता है, एंड लास्ट 20 to 25 years what has changed in brain and spine surgery that we should tell. We should tell our relatives, we should tell our all the peoples, we should give the message because you are the best for that why it is so safe nowadays. Okay, so just I want to give attention to this two image. This is kind of quiz. ये दो image है, first and second. What is the similarity between these two images? First image and second image. So first is anybody?
Very sharp.
Yeah?
Very sharp. Very sharp. That is low.
No, that is okay, perfect. What is the content? This is Milky Way galaxy. Thank you, sir. What about the first? First. Absolutely. So 41 years lady underwent epilepsy surgery 3 years back in USA. उसका ये biopsy है. And now, so this is all the neurons and this is our stars. So what is the connection between it? Dr. Vani, ma'am, any idea? What is the connection between these two? So we have,
The number of stars in our galaxy.
yes, absolutely. So this is 86 to 92 billion. 86 to 92 billion stars in the galaxy, 86 to 92 neurons in our brain. And this is God creation. So that is one of the reasons there is a magic in the neuroscience. One of the reasons I become a neurosurgeon. Okay, so this is the fact. There are 100 trillion neuron connection and 2.5 petabyte memories. So 1 petabyte is equal to 1000 terabyte. Now, second question, which is the best or we can say strongest species in the world? The strongest species in the world available existing in this universe, which can even beat this. Strongest species, maybe there are equal numbers, but some male can, that can be had in just 5 minutes. And somebody agrees, but जांचने की जरूरत नहीं है. We went through this research and he said female brain is more powerful than a male brain, and it's absolutely true in the science. There are faster connection, more memory in the middle age, and this is proven. So this is fact. Well, that is the fact. Maybe male has lot to do. If you compare the male and female brain difference, we are very busy. So now coming to the point. So in 19th and 20th century, there were some myth by surgeons. चाहे कोई भी surgeons हो, we should go with the complete removal. We were treating the radiology. चाहे ट्यूमर है तो पूरा निकालना है, जो भी डिस्क प्रॉब्लम है तो पूरा निकालना है, इवन GI प्रॉब्लम है तो पूरा निकाल. We were behind the radiology treating. Now in 21st century, the goal is changed to a maximal safe, so more functional outcome. So we need to remove the tumor and pathology, but give more functional tumor. We should not change the radiology. And that has happened in last 21st century. And I think in neuro and spine, game changer is advanced image guidance, intraoperative neuro monitoring, and advanced endoscopy. According to me, these three is the game changer. So let me share you my journey of 1000 brain tumors in 15 years. So first of all, I would like to give one suggestion to all of you. We can say suggestion, we can't say advice. We all are seniors to me maybe. Any patient if having headache more than 6 months, please go with the one plain CT brain. One plain CT brain. I'm not saying contrast because there is some confusion ki kaun sa karau CT scan. Plain CT brain. Out of, according to Indian Advanced Registry System, there are 28,000 tumors, brain tumors detected in India. अगर किसी को 6 मंथ में हेडेक है और आपने एक प्लेन सिटी किया और किसी में भी एक लीजन निकल आया, you have changed their life because it's a low grade tumor. It is completely acceptable. So in 7 to 8 days, low grade tumor become high grade. So this is the chance. If more than 6 month headache, please go with the one plain CT brain. This is my message. Now what is changed in radiology? So now we have this kind of sequence, MR spectroscopy. Yes?
सीटी स्कैन जो करवाते हैं ना, तो वो लोग 2 प्लेट देते हैं, 3 प्लेट देते हैं, 1 प्लेट देते हैं, तो क्या
एक प्लेट देते, 2 प्लेट, सीटी स्कैन में एक
वो
ही.
जो एक प्लेट देता है, कोई 2 प्लेट देता है, कोई 3 प्लेट देता है.
सो एक्सेल कट, कोरोनल कट, सजाइटल कट ये हो सकता है. किसी का बहुत हाई एडवांस 128 चैनल हो तो वो मिलीमीटर का डिफरेंस हो सकता है. बट द आइडिया इज टू डिफाइन सम स्पेस ऑफ ओपा इंग्लिश.
Is there a difference?
No, it doesn't make any difference. अगर आपको डिटेल में जाना है देन यू नीड एज फॉर सर्जिकल एस्पेक्ट की एक्सेल कोरोनल सजाइटल इमेज. फॉर द डायग्नोसिस वन प्लेट इज इनफ. ओके, सो दिस MR spectroscopy tell you about the chemical inside the lesion. क्या केमिकल है. Now based on chemical we can say ये benign है कि कैंसर है. Functional MRI will tell you exactly the direction of the fiber, white fiber जो है ब्रेन में, white fiber है, grey fiber, exactly कौन सा कहाँ शिफ्ट हो रहा है. Diffusion traction image same, water content, and we have this navigation like हमें कहीं से कहीं जाना है, so now we just put a navigation कि हमें घाटकोपर जाना है, we just put it in the tell you. Similarly in the brain and spine we have this navigation system. आप preoperative data उसमें लोड कर दीजिए. During surgery this navigation will tell you exactly where we are working. Not only that, how much surgery we have completed and how much is remained. So these are some advanced things. Like what is changed in intraoperative surgery? So what we do a keyhole surgery. Rather than complete craniotomy, we make a hole and do our surgery with this awake craniotomy and endoscopy. Awake means patient remain awake. There are some anesthesia in which patient can remain awake and you can accomplish the surgery. The idea is you can evaluate the deficit, neurological deficit during surgery. So बाद में नहीं पता चलेगा इसका पैरालाइज हो गया, ये हो गया. During surgery you can have idea. We have comprehensive team approach of all of this. This is our operation theater with all advanced things. Like this was a patient came from peripheral of Maharashtra, so 45-year male, and at that time we can see here we had just a headache. The MRI is suggestive of this cystic tumor. And we can see that this is on the left side. Now this area we call posterior frontal region, frontal lobe. So this is around the speech area. Where is it? The speech area and is a motor area. So if you want to operate, so how should be the best idea to operate? So first we'll not do craniotomy, rather we make a exactly hole over that so that the minimal invasive approach can be taken. Second, we can make him awake during anesthesia. So the chances of कॉम्प्लिकेशन इन दिस सर्जरी, उसको एफेजिया हो सकता है, स्पीच जा सकती है और पैरालिसिस हो सकता है. सो व्हाट द बेस्ट कैन बी डू ड्यूरिंग सर्जरी, वी कैन टॉक विथ हिम. सो सर्जरी इज गोइंग बैक. सो ड्यूरिंग सर्जरी वी आर प्रैक्टिसिंग, वी आर वॉचिंग द फंक्शन ऑफ राइट हैंड एंड ही इज काउंटिंग. सो दिस इज वी कॉल्ड अवेक क्रेनियोटोमी. So during surgery, जैसे complete होगा, we are 100% sure there are no speech problem, there are no weakness. That is the best. The second day, patient can walk because we have made just an endoscopic keyhole, and because he was very spiritual, so he was requesting कि I can't say English and all those things. So हमने कहा ठीक है, आप अपना श्लोक बोलना.
Second day of the surgery.
Yeah.
Second day of the surgery.
Second day of the surgery. So this is the advanced neurosurgery. Now what is the new era minimal invasive brain surgery? So there are keyhole brain surgery. We make just a 1 rupees coin hole over the whatever the lesion, either hematoma hai, brain tumor hai, whatever it is. Second, we go with endoscopy all through nose. All the skull based tumor or skull based lesion can operate through nose. These are the two changes. What is the difference? Smaller incision, less exposure to the normal brain structure, no brain retraction, no pain. Patient can be discharged on day 3 or day 4. And because patient discharges early, it is more economical. This lady came from periphery of Maharashtra. The 36-year lady, we can see the CT. There is a colloid cyst. Patient has hydrocephalus, like headache, hydrocephalus. So again, the navigation, we mark the hole. Without instead of craniotomy, we'll directly decided to go with the endoscopy. So let me take you inside the brain. So how we do endoscopy? So this is our lateral ventricle. We are here, and this is the cyst. This is white color is cyst because it is came on the way of foramen Monroe, the CSF pathway. So this is obstructing the CSF pathway. This is colloid cyst exactly. And she is just a 36-year lady. Choroid plexus, all the ventricles inside the brain picture. Now the same thing we do in the open surgery, we can proceed in the endoscopy and we can remove the complete cyst with just a 1 rupee size coin hole. Opposite side. So that colloid cyst is gone, and so post-operative hydrocephalus we can see in the post-op MRI, there is no colloid cyst. So this is the advantage of endoscopic spine surgery, endoscopic brain surgery, sorry. Post-op CT, and patient can discharge on day 3. Another intraventricular tumors like meningioma we can operate through endoscope. I'm giving you the glimpse. Now you have heard about subarachnoid hemorrhage. Patient come in your emergency with severe headache, acute headache, young patient. You do the CT angio and you can see there are aneurysms. Everybody knows there are coiling options. Coiling, my colleague Dr. Rishabh Chadha will tell you about all the interventions specially. But if patient is not affording, coiling का 10 लाख लग रहा है, 9 लाख लग रहा है, 8 लग रहा है, patient के पास ये नहीं. Now there are option of minimal invasive aneurysm surgery. This is a young male, 25-year patient with subarachnoid hemorrhage, and the CT angio shows this MC aneurysm, subarachnoid hemorrhage. So we give eyebrow incision. We go through here, eyebrow, and we make a hole here just above the eyebrow. This is 1 rupee bone flap we just raised. We open the dura. So we are inside. This is optic now. Yeah. So this is the aneurysm. You can see here. This is the internal carotid artery, both the channel, and this is the aneurysm. So we can apply clip directly. So there are 2 treatment of aneurysm. Either you apply the clip over the neck, that is the immediate permanent treatment, or either you coil it. Both are equal. And after 6 months, even we can't see any mark. I'm just giving you a glimpse how the advanced brain surgery can be done and what are the possible options we should know. So at least we can discuss with the patient. Like vestibular schwannoma with hearing loss, patient come with that. So what is the advanced thing? We can make a hole behind the ear, can go through the endoscope, and we can remove the vestibular schwannoma with 7th nerve hearing. Neuromonitoring. We have now intraoperative neuromonitoring. So 7th nerve can be preserved, which is attached to vestibular schwannoma. So post-operative, we cannot preserve the hearing after any vestibular schwannoma surgery, but we can preserve the facial function by the advanced brain surgery. Facial pain syndrome. Many patients you must have heard. Either pain हो रहा है, typical one-sided. V1 area, V2 area, V3 area. ब्रश करने में पेन होता है, सुबह पेन होता है, शाम को पेन होता है. 5 drugs, 7 drugs. I want to suicide. I don't want to continue these things. Please कुछ करिए. डेंटिस्ट को दिखा दिया, डेंटिस्ट ने दांत निकाल दिया, फिर भी पेन नहीं जा रहा है. Typical complaint of trigeminal neuralgia. Only one side cannot be on other sides. If it is other side, it means it is a atypical facial pain syndrome. If it is on one side, it is a classical trigeminal neuralgia, electric current like pain. What is the 5th nerve? This is the 5th trigeminal nerve. उसके बाजू में 2 vessels जाती है, superior cerebral artery. If it is giving a continuous current, continuous pulsation over the 5th nerve because of abnormal course, this will give you a trigeminal neuralgia. So there are, okay, please, कुछ में endoscopic spine surgery करना. So there are that pulsation. Now the common treatment, we give gabapentin, we give baclofen, we give pregabalin, still patient not treated. So if you ask me what is the permanent treatment, is the microvascular decompression. We can go through the endoscope here. Now this is the 5th nerve and this is the vessel I was talking about. So what we do, on the base of that 5th nerve, we can apply some Teflon. So this is a Teflon structure जो cardiovascular में use होता है. We just put this Teflon between the fifth nerve and that vessels, and this is a permanent decompression of that nerve root, and next day patient can be pain free. And it has a 98% guarantee, 98% guarantee of permanent pain treatment. This is called microvascular decompression. Now it become endoscopic decompression, so it's required just one keyhole. This is the only standard treatment of the trigeminal neuralgia. So like this, Teflon.
महिन्यांनी एवढं दुःख लागलं का म्हणून अक्षरशः खाली डोकं ठेवून द्यायची नाही मी रडत
Was in the pain since 8 years, absolutely
मग ऑपरेशन झाल्यावर
Tried everything.
दुखणं कमी 1 महिना
and cured. So this was the idea. Thank you. So now some idea about how to do transnasal surgery without, that is, incision-less surgery.
So we have with us this slides. Sorry to interrupt, sir.
Yeah. Dr. Jayesh sir.
We have with us Mr. Amit Raj Sahib Thackeray with us. So, and you know, our is Dr. Sanjay Borode sir.
Sorry to barge in like this. Extremely sorry for that. Myself, Dr. Sanjay Borode. I'm a bariatric surgeon.
You don't know any introduction.
Thank you so much. I would like to take this opportunity with extremely short notice that we were here, my friend Anil Pashnikar.
Is on the very summit.
He is my classmate and the dearest buddy. म्हणजे जो सगळ्यांचा पण आहे त्याला मी वेगळं काही सांगायला नको सॉरी सो Amit is my son-in-law. So whatever we were friends, we are all friends. So wanted to introduce Amit, and this is my humble request to everyone. He is now contesting election from this area. I can vote for all these things, and I would be obliged, very highly obliged with you, every one of you. Please support Amit to take every possible problem in this Miami. I would handle my mic with me, and we can also have a few words.
अरे आले सर आले.
सर्वांची प्रियकर आले.
आपल्या
अनिल
ठाकरे तुम्हाला ओळख द्यायची गरज नाहीये कारण बाळासाहेब ठाकरे राज ठाकरेंची परंपरा त्यांनी महाराष्ट्र गाजवलेले आहे त्यांचे सुपुत्र आपल्यासाठी आलोय हे आपलं भाग्य आहे मोठं जरा जोरात राहायचा आवाज तुम्ही पाहाल तर अमित ठाकरे आपल्या विद्यार्थी देशामध्ये विद्यार्थी प्रश्नावरती झगडत होते समाजकारणात झगडत होते आणि अशा प्रकारे आपण त्यांना विधानसभेत पाठवून देऊया ज्याने आपल्या माहीम धाराविक प्रश्न मार्गी लागतील आपल्या सगळ्यांना एक मदतीचा आधार मिळेल तरुण आहेत तळमजूर आहेत कर्तव्यकर आहेत धडाडीचे पण माझा जो बॅटमॅन डॉक्टर संजय बोर्डे जो फर्स्ट इयर पासून माझ्यावर मेडिकल कॉलेजमध्ये आहे त्याचा नाव आहे म्हणजे आपल्या सगळ्यांना नाव आहे आपल्याला पाहिजे Good afternoon, everybody. For the once again, sorry to interrupt your session, but I was told by Sanjay sir की अशा इकडच्या महत्वाच्या डॉक्टरांची बैठक झाली आणि आपण त्यांना भेटायचं म्हणून मी आलो. मी इकडनं उभा आहे, तुम्हाला माहिती आहे. माझं नाव अमित ठाकरे, मी राजसाहेबांचा मुलगा आहे. मी तुम्हाला एवढंच सांगेन की सोसायटीला जर कोणाला विश्वास असतो तर तो सगळ्यात जास्त म्हणजे डॉक्टरांवर असतो. आणि मला वाटतं की तुमचा जर माझ्यावर फक्त विश्वास असेल तर तुम्ही पुढे पसरवा, नाही तर पसरवू नका. पण मी माझा एक प्रामाणिक प्रयत्न करतोय. आपलं माहीम एरियामध्ये आपण, मला वाटतं सगळे माहीमचेच आहेत, सगळे माहीमचे. सो माहीम दादरमध्ये आपण सगळे वाढलोय. माझी 32 वर्ष गेली, तुमच्या अनेक वर्ष गेली. माझा आता मुलगा आहे. त्याच्यामुळे आपल्याला विचार करायला पाहिजे की माहीम पुढे चाललंय की पाठी चाललंय, मुंबई पुढे चाललंय की पाठी चाललंय. जर तुम्हाला वाटत असेल पाठी चाललंय तर मी त्या दिवशी एक उदाहरण दिलं की डॉक्टर्स आहेत, त्याच्यामुळे हा उदाहरण सगळ्यात जास्त तुम्हाला कळेल की जर एक माणूस आजारी असतो आणि डॉक्टरांकडे गेल्यावर ट्रीटमेंट नाही मिळाली तर आपण परत त्याच डॉक्टरांकडे जात नाही. तसं आपलं राज्य, कुठे देश, कुठेतरी आपलं शहर, आपला एरिया कुठेतरी आजारी पडत चाललंय आणि आपण त्याच डॉक्टरांना निवडून देतो. त्यामुळे मला वाटतं आता डॉक्टर बदलण्याची वेळ आली आहे. जर तुम्हाला माझ्यावर विश्वास असेल तर मी तुमच्यासाठी प्रामाणिकपणे काम करायला तयार आहे. आणि मी एवढंच तुम्हाला बोलायला आलोय की कारण शेवटी डॉक्टरांचा जो रिस्पेक्ट असतो सोसायटीमध्ये तो सगळ्यात सर्वाधिक असतो. त्याच्यामुळे माझं ऑनर आहे की मला तुमच्याशी बोलायला मिळतंय. पण माझी अशी इच्छा आहे की बरेच ठिकाणी हाय रायजेस मध्ये वगैरे आपण 20 तारखेला निवडणूक असेल तर आपण उतरत नाही. मतदान करा, कोणालाही करा, पण उतरा, एवढी माझी प्रामाणिकपणे इच्छा आहे. त्याच्यामुळे मी एवढं बोलून थांबतो आणि तुमचं सेशन सध्या तुम्ही बोला, तुमचा विश्वास तुम्ही बोला.
बदल हा हवा आहे आणि पुढे आता म्हणाला किंवा तरुणांकडे दिलं पाहिजे. सरळ बोलणार राजा आणि पिस्तूल काढणारे लोक आकडे द्यायचे का पुन्हा
ज्यावेळी महाराष्ट्राच्या लोकांना आमचे पाचवीकरता घेऊन आले तो प्रत्येक जण आजपर्यंत जिंकला. आणि सेकंड थिंग, जेवढे लोक आहेत आय थिंक दे आर मीटिंग हंड्रेड्स ऑफ पीपल एव्हरी डे. सो यू कॅन ट्रान्सफर ऍटलीस्ट 10 पर डे टू
इनफॅक्ट ह्या बाबतीत मी म्हणतो की मी मोठेपणा सांगत नाही माझा, पण माझ्या एरियामध्ये कॉर्पोरेशन इलेक्शन लावून दे, एमएलए लावून दे किंवा एमपी लावून दे, सगळे मला भेटतात. कारण मला भाषणासाठी दिवसाला 200 रुपये बोलतात, पण इथूनच पिक्चर चेंज होतं. आय हॅव मोर लेडीज पेशंट्स सो दॅट यू नो आय कॅन टेल माणूस चांगला आहे, जेन्युइन आहे, जेंटलमन आहे, तुम्हाला काय गरज लागेल माझ्याकडे या, मी तुम्हाला घेऊन जाऊ शकतो, तुम्हाला मदत करू शकतो. रिस्पॉन्स यू नो वन दे हॅव द फेथ ऑफ द डॉक्टर्स and the doctor says something out of medical and all, then they try to believe in it and they मला नंतर भाभी लोक घालतात डॉक्टर
भाभीला सांगितलं सर, भाभीला सांगितलं भाई पण पटतो ना सर, ते जाऊन त्याच्या घरी प्रेशर करू शकतात.
रजिस्ट्रेशनला त्रास होतोय, बायोमेडिकल वेस्टचा प्रॉब्लेम होतोय, चेंज ऑफ द नेम ऑफ द नर्सिंग होम ह्याच्यासाठी भयंकर त्रास होतोय. आज आमचे सिनियर डॉक्टर राजेंद्र गोपाळे साहेब आहेत, त्यांचं फार मोठं नाव आहे एरियामध्ये, म्हणजे आम्हाला एवढा त्रास होतो. मग अशा वेळेला आम्ही जायचं कुठे? वी आर एक्सपेक्टिंग दॅट इंडियन पिनल कोड मध्ये हे यावं. आता भारतीय न्यायसंहिता आलेली आहे, कारण जोपर्यंत भारतीय न्यायसंहितेमध्ये हा कलम येत नाही तोपर्यंत पोलीस स्टेशनला काही कळत नाही की डॉक्टरांवरती अटॅक झाला तर काय करायचं, कुठली ऍक्शन घ्यायची, काय घ्यायची. आपण बघितलं आमची कोलकाता मेडिकल कॉलेजमध्ये काय झालं, डॉक्टरांवरती मर्डर झाली वगैरे. अरे डॉक्टर तुझ्या बहिणीला कधी त्रास द्यायचा प्रॉब्लेम नाही करणार, काहीतरी अगदीच घडू शकतं, पण त्यासाठी कायदा आहे, सुव्यवस्था आहे, असं कायदा हातात घेऊ नका, त्यासाठी आम्हाला तुमची मदत लागणार.
आमदार कुठच्याही खासदार त्या एरियाचा बॉस असतो, बॉस तुम्ही लोक असतात जे त्यांना निवडून देतात, त्याच्यामुळे त्यांनी बॉस म्हणून नाही तर ट्रस्टी म्हणून काम केलं पाहिजे आणि मी हे नक्कीच तुमच्या आशीर्वादाने करेन. थँक्यू.
Thank you. Again,
Dr. Gopani sir, Dr. Fatima sir, Dr. Kulhali sir, please Dr. sir and Amitabh.
Thank you so much. Thank you everyone. Thank you. Sorry.
सांगायचं सिम्प्लिसिटी ऑफ द अमित की माझ्या बाजूची शेजारची मुलगी होती, तिचं ते डॉक्टर अमित तर मी त्या रस्ता बंद होतो म्हणून रक्तन गेलो होतो, अमित चालला म्हणून म्हणजे काय काका काय पण भेटला अमित एवढं मोठं नाव वगैरे असं रस्त्यावर चालेल का, अरे म्हणलं आपलं शिवाजी काका बच्चा म्हणलं आम्ही करतो नाही किसे म्हणलं नो प्रोटेक्शन नसते. आवाज
It is on. Let it be. This is for you.
Sorry for interruption, sir. Please.
Okay, please off the light. Okay, so we have seen how we do. Answer? No. It's okay.
Back to our railway.
So we have seen how we do advanced brain tumor surgery through just a hole. Now I will take you more forward. How we do surgery through skull-based approach, through transnasal surgery like craniopharyngioma, pituitary adenoma. We may have heard that kind of name. So this is the pituitary adenoma. Pituitary adenoma, basically tumor of the pituitary gland. And this is two types, functional and non-functional. So functional means it increase the hormone, like disease like acromegaly, जिसमें हाथ पैर बड़े हो जाते हैं, and non-functional, which is not secreting any hormone but compressing the optic nerve. Patient usually present with a vision loss. So this patient, this lady, she was a secretary of some giant company and she presented with acromegaly. Look at the face. So immediately face change, nose change, उसके size of hands and legs increase, foot size increase, growth hormone which is normal 0, normal is less than 2, it become 15. And we came to know, okay, there are the pituitary adenoma. We commonly see this kind of, right? So how we do that kind of surgery? completely through nose. So for that we create a space through paranasal sinus, and this was the red color. This is the tumor. This white is not. This is the tumor. So we basically make a hole in the skull base. Exactly, we call it cella, and from there we can enter in the brain. We can operate starting from frontal base to up to end. That is without incision. So like this, we are removing the tumor. And just give you a glimpse how we do that. And after that, we cover that hole with the nasal mucosa. In 5 days, it becomes healed, and day 3, we can discharge the patient. And immediately after that, the growth hormone value become less than 2, which is normal. That was pituitary adenoma. Now there are other tumors like craniopharyngioma, giant pituitary adenoma. Everything can be possible to nose. The vision loss is 2 types. One is which is chronic. If patient have a chronic vision loss, if you do the fundus, if there is a primary optic atrophy, the reversal of visual loss will be less. If there is a chronic acute atrophy, अगर किसी का immediate vision गया है short time से, if you do the surgery, patient vision can be reversed. Like we can see this 50-year male patient with a bilateral vision loss since 7 to 8 days. And we can see there is a brain tumor, craniopharyngioma. And same to nose, this is the skull base. So this is without surgery is being happened through the nose. We can open the skull base from the base. These are the instruments we use. We open the dura through endoscopy. We can go inside the brain, and this is the tumor. This is our normal pituitary gland. This is stalk. This is a normal pituitary gland. This is the tumor. These are the right optic nerve, left optic nerve. We can see this patient had a vision loss because this tumor was compressing the optic nerve, and that's why patient had both the vision loss. So through nose we can go there. We can remove the tumor, with of course preserving all the glands and all those things, and patient vision can be improved in the next 15 days. So these are the advanced transnasal endoscopic skull base surgery. So we can remove, yeah. Size is approximately, you can say 3.5 into 4. And we can completely remove it. And after that, we can close the skull base through this nasal fascia. So these are the endoscopic skull base surgery. Many tumors, we can, even giant tumors, we can operate through the nose like this. These are the large giant tumor intraventricularly that gone through back. Now what about the intraventricular hemorrhage? We have seen in last decades, even a young generation, it was initially started with 50, after हमने सुना था 50 साल बाद hemorrhage होता है. You see in the last decade, 25, 35, 42, they are coming with the hemorrhage, intraventricular hemorrhage. Now the conventional treatment is we open the bone, we keep it outside, we remove the tumor, we allow the brain to relax. Other advanced measure is you just make a hole here in the frontal bone. You can remove the complete hematoma through endoscope. You can remove the large volume of CSF also, so brain can be relaxed because the pressure changes is not much, and there are only the minimal invasive neurosurgery. Patient's recovery will be faster, no chance of infection, and ventilator requirement is very less. One of the leading physician of the Kalyan, and he presented in last month even, and he was in M5, unconscious sudden hypertensive hemorrhage. We discuss the option, we make a burr hole, remove the hematoma, the picture after 4 months. And he is practicing right now. So this make some difference through endoscopy. Now 2 words about pediatric neurosurgery. So pediatric patient come to you. So there are questions. अगर 6 month का है तो ऑपरेट करना चाहिए कि नहीं, 3 month का है तो ऑपरेट करना चाहिए कि नहीं, 2 साल का है तो ऑपरेट करना चाहिए. And usually they present with what? The back and the swelling, like back swelling, we call meningomyelocele. So please remember, if there are open defect, what we call open defect and closed defect, if there is a CSF leak from any swelling from the back, you should immediately operate irrespective of the situation within 36 hours. नहीं तो infection brain में चला जाएगा, meningitis हो जाएगा, then it becomes irreversible. If irrespective of the swelling size, if skin is closed, if there is no deficit, skin is closed, sorry, irrespective of the deficit, but कोई leak नहीं है. You should wait at least for 3 to 6 months till child develop. At least hemoglobin, which is normal, can be operable, and after 6 months we can utilize the neuro monitoring. So if limb is intact, visually in pediatric patient, I am certified pediatric neurosurgeon also with 1 year fellowship. With neuro monitoring, you can track all the nerves which is going in the spinal cord, so you can preserve that. But before that, at least 6 months you require. So again, I am repeating, with CSF leak, immediately operate within 36 hours. Without CSF leak, you should allow her to little bit grow. So this was the first youngest child in the literature, and even in Fortis, is presented in Fortis Mulud, and she presented with leak from year back, and 12 days baby. This was the dermoid tumor. Because there were a leak, we immediately operated. This was the dermoid tumor, 12 days baby. We published also, that's why I'm saying it's a youngest child. It's called spina bifida, and the tumor was the dermoid cyst. So this kind of the limb remain intact. So this the glimpse of pediatric neurosurgery. Again, 1.5-year child, Morquio syndrome, youngest children in C1 C2 dislocation. It was kind of syndromic C1 C2 anomalies, and we can still fix this kind of problem. Now, last part of topic, that is spine. What has changed in the spine? 18th to 19th century, we had to remove, this is the spine. For any spine problem, we open the large incision, we had to open, we had to remove this complete lamina, and then we operate. Then it comes to mini open technique. Now we are operating just a 6-7 millimeter endoscope, 6 to 7 millimeter endoscope. So conventional open spine surgery to sutureless spine surgery, the advantage is look at the incision, now look at the incision. So tremendous patient can be discharged in the 48 hours. Now, सबके पास बैक पेन के पेशेंट आते हैं. I'm sure everybody has hit that. So how to give them the algorithm? क्या करना है, क्या नहीं करना है? So this very important slide. So patient come to you. First test, back pain or leg pain. The first test should be SLR. We call it SLR, straight leg rising test. So what you do, you just make her or his spine, and then ask him to elevate the leg. So if he complain of pain in the back, after 30-degree elevation of the leg, it means the nerve root is somewhere compressed in the spine foramen. This we call SLR positive. Just a single test will give you so much information that you immediately come to know, okay, slip disc hai. So slip disc hai, slip disc nahi hai. This is a wonderful test, SLR test, right? So there are two scenarios. So one patient came with the back pain, acute back pain hai, right limb radiation or left limb radiation. You done this SLR which is positive. Next test, MRI lumbar spine. Now आपको और क्या देखना with SLR? Kindly check the foot. Foot में toes, because toes is supplied by L4, L5 and S1. If there are weakness, you can immediately note that. Right? तो दो ही चीज देखनी है. In MRI, so there are SLR positive, AHL positive. MRI में लिखा हुआ है there are diffuse disc protrusion, extrusion वगैरह वगैरह वगैरह. See, diffuse disc bulge has nothing to do with patient. सब में यहाँ पे जितना भी हमारे करेंगे 80% में diffuse disc bulge word आएगा. It doesn't mean that it is operative case. If EHL positive, if SLR positive, severe radicular pain, then it is significant, right? So if it is all this positive, we advise endoscopic discectomy. Patient can be discharged in 48 hours. Second scenario, बैक पेन है, थोड़ा चलता हूँ, दोनों पैर सुन्न हो जाते हैं, पैरों में झंझनाहट हो रही है, बैठना पड़ता है, बैठने के बाद ठीक हो जाता है. Classical neurogenic claudication we called it. It means patient is having lumbar canal stenosis. उसमें भी diffuse disc bulge जाएगा, but there are canal stenosis. So what you do, go for MRI. If the spinal canal is more than 11 millimeter and patient को कोई deficit नहीं है, no need to operate. If it is less than 11 millimeter, patient को relatively deficits है, sensation loss है, we should go with the endoscopic decompression. Patient can be cured in 48 hours. Third scenario, which is very common I can see nowadays, there are hip pain which is radiating to the thigh. Patient को typical first stage में pain हो रहा है, patient को करोड़ बदलने में pain हो रहा है, classical sacroiliac joint arthritis. SI joint block we give, that is a steroid we put in the SI joint block, and immediately patient can be treated, or just by some medicines. So these are the algorithm which help. Now, what are the reasons behind the spine wear and tear? So these are the disc. This is called, these are the outer side plastic layer called annulus. Disc material. Disc material is always jelly-like. 80% उसमें water content है. So once age grows, this water content is reduced. So उसका जो jumpiness है, जो jumper-like action is reduced. This becomes stiff. The joint become hypertrophied with the age. So what happened? Gradually, with the movement, there are the prolapse. It gets starting compression of the nerve root. So this is classical called slip disc, because nerve is exactly behind the disc. And this is the, we call it slip disc. So both the side there are right nerve root, there are left nerve root. Behind the disc there is a foramen, where there is a normal, there is a space behind this foramen. Now, with all the position, this foramen will never going to compress unless there is a leak from the disc and it is compressing the nerve root. So this was the conventional thing. Now what we can do with this kind of slip disc, we just put a guide wire there, exactly over that disc. There are 6 mm endoscope. Through the hole from the back, we can put it there. There is a seat. We just target that only herniated segment or herniated part. We never remove the complete disc because it is a physiological thing. Then we make sure that one side and both the side nerve root is free, and with that just a 6 mm hole, patient can be cured and patient can be discharged. So this is advanced endoscopy. This is a Korean system. So particularly we train through the, yeah. So this was the lady. She came with this alpha S1 disc prolapse, acute disc prolapse, left side. Patient unable to walk. Everything has been tried. So we put an endoscope. This is the nerve root. So we are in the spine canal. This is the white color is a disc prolapse which is compressing this nerve root. Just giving you an idea how we do endoscopy. Yeah, so this white color is disc, that's a prolapse disc, damaged disc. We remove that fragment and immediately the patients, once we remove that, yeah. Yeah, so this is the nerve root which is completely free now. It's just a half-an-hour job. So all spinal canal is free. So less than thumb size incision, and the next day in morning we allow the patient to walk, and next day evening patient can be discharged. Okay, just few 3-4 slides. If some patient had an instability in the spine, we call it spondylolisthesis, we put this kind of guide wire through the skin, and through the skin we can put this kind of percutaneous pedicle screw fixation without opening it, and we can fix the problem without open things. So these are the patient, like we call it MIST-LIF. My teacher, Professor Takayasu and Dr. Lim, to Korea and Japan. Now last segment, if patient have a neck pain, so there are two complaints, either continuous neck pain or neck pain which is radiating to one hand. Either if there are two kind of disc prolapse in the neck, either center disc prolapse or on one side there is this called far lateral disc prolapse which is compressing one nerve root, and patient have only ipsilateral hand pain, so right or left. So there are two options, either you remove complete disc, because you remove the disc there will be instability, you have to fix with the spacer, we call it SCDF and SCDF, right, NDS cervical discectomy infusion. Nowadays the era is a motion preservation surgery. पेशेंट का नेक का मोशन रहना चाहिए. So there are two options. Either we can go from back without any instrument. We can directly go through endoscopy. We can remove it. It doesn't require any instrument. Doesn't require any implant. Other is we replace the disc with artificial disc. Both the case, the motion of the cervical spine can be preserved. One of the renowned pathologists came to my OPD just 3 months back because उसको microscope में देखना रहता है. So in 7 days he had a severe pain, right side, severe pain. This was this disc collapse C6. So मैंने suggest किया okay discectomy करते हैं. But she was saying कि अगर फ्यूज कर देंगे तो मैं माइक्रोस्कोप देखूंगी कैसे. So we discuss other option. Okay, let's go through the endoscopy. I just will shave this kind of disc and your nerve root will be free and you doesn't require any implant or instruments. She said okay. This is the endoscopy system. This is the cervical spine. We are going through back. This is the spinal cord, the C6 nerve root, and we can remove the disc from here. We can decompress the nerve root. Because we are going from back, all the joint is intact, the disc space is intact, we doesn't require any instruments. Yeah, of the surgery, this is the nerve root which is free. And the neck pain completely resolved and patient can discharge on day 2 and patient in 7 days patient can rejoin the job. One patient from Dubai, complete disc collapse anteriorly. So he said, I want to keep my motion because my job is like that. I put this artificial cervical disc. During surgery, we can see the cervical flexion and extension, that motion should be intact. It's very costly, 1.5 to 2 lakh, but this is possible. Complex kyphoscoliosis also we can correct. So thank you so much for your time. And so the idea is, after removing this disc, part of the disc. So this is part of the disc. Normally, disc is not degenerate, it is normal. Once it becomes degenerate, it's become pathological. That fragment become separate from the normal physiological disc that came into the canal, that compressed the nerve root. If we remove that part, the normal physiological disc, what is the remain, we make coagulate that. So in 7 days it make a layer there. So it become ill. So the chances of recurrence is less than 1%. Unless the patient will gym karna chalu kar de immediately or after long time. Otherwise, in I don't think so, less than 1 or 2% chance of recurrence. So, I have one announcement. So this was about the brain and spine surgery. So in my team, I have Dr. Rishabh Chheda. So he does all the intervention, neurovascular intervention, and just trained from Japan through neurovascular intervention. He just give you an idea about neurovascular intervention in 5 to 7 minutes. Come, Rishabh.
I'll just go through the images of what exactly we are doing. Okay. So, jokes apart and everything. Very routine case which you guys would be getting in your daily practice. Stroke. Many a times there is a question that what exactly needs to be done, whether patient will improve, will not improve, life-saving, non-life-saving. Many a times there are questions as in patient la weakness bolta yenar. So just one case, 80-year-old female patient had ICA block. Brain supply to the blood supply to the brain was completely blocked. If you see on the upper corner left, 2 images, that is the IC of the right side. It is showing blood supply to the right side of the brain, some part to the left side of the brain. The last 2 images, left IC is completely blocked. So we've gone in with a balloon, we've pre-dilated it. Same thing, something which is done by cardiologist initially. Now the neurosurgeons have been doing. We've opened up the ICA. In the later imaging, you can see there is MCA block. So we've gone in with a stent retriever, stent given, we've taken out the clot. 80-year-old female, she presented with right-sided weakness and aphasia because this was a dominant hemisphere. Patient on second day was back on her feet. She was able to talk. She was discharged on the third day, reciting her daily prayers, whatever she is doing. So that is the power of neuro intervention. Many ask why a neuro intervention and why something that costly to be done. But I think an 80-year-old female given back the functional help of her daily life and reciting a prayer is invaluable. It cannot be counted in money. So ideally, the golden hour, the 6-hour period, is the best when the patient has the best recovery. Because the time is brain, we get more neurons which can be recruited back and the functionality can be preserved. Higher the time, the results go on changing. But especially for posterior circulation strokes like cerebellum stroke or brainstem strokes, these patients can undergo thrombectomy for at least 24 hours and with good results, with minimal deficits. I would not say that all patients come out without deficit, but maximum functionality is the aim in the end of the surgery. A few cases like aneurysms are told the clipping of the aneurysm. Total cost at Raheja, the hardware costs somewhere around 3 to 4 lakhs, plus the additional cost related to the ICU and all those things. It might go somewhere around 5 to 6 lakhs. But if you account for the functionality that is preserved for the patient, if the patient is functional at the end of the surgery, that is what in the end it counts, I feel. Few cases which sir showed through transcranial, we do it intravascular. So that is the added benefit of we working as a team. We can give an entire range of treatment options available. These are aneurysms which can be balloon coiled or stent coiled or various different aneurysms and various different location of the aneurysm which can be coiled. This is one of the patients which we had surgically clipped and patient had aphasia, could not speak. We went in with our catheters, gave her injection nimodipine. On table, the patient had recovery of speech. So that is one of the additional benefits of doing intravascular surgery. Patient having stenosis, ICA stenosis, something very much similar to the cardiologist which they have been doing in the limas and the remas. The patient had carotid stenosis, left ICA. We've gone in and we've stented the vessel. Patient has had 90% stenosis and was recurrent. He was having recurrent TIAs, transient ischemic attacks. That is why we had done a DSA, and this patient was stented later on. We could do an endarterectomy also. Patients who are not affordable can undergo endarterectomy also. This was published by our team with the protocol. This was the clot which I was talking about, which was retrieved from the first case. Small vessel stenosis, which can be stented. 4-year-old young child presenting with strokes. Generally, these patients are diagnosed with Moya-Moya syndrome. What is Moya-Moya syndrome? It is congenital abnormality in the vessel, ICA vessel, supraclinoid segment of the ICA. So in these cases, we do bypasses. The vessel ahead of the ear, the superficial temporal artery, is joined with the middle cerebral artery, and the patients recover from the deficits. Hypertensive bleeds has already spoken about, arteriovenous malformations and fistulas, and that's about it. So this is the entire range of vascular intervention that we've been doing.
Sir, it's very short and sweet, but we will definitely love to hear you for hours.
Definitely.
To felicitate Dr. Jayesh Shardhara sir, I would like to call Dr. Rajesh Kulhali sir, Dr. Singhapurkar sir, Dr. Singhapurkar sir, Dr. Vinod Jain sir, Dr. Anil Pagnekar sir.
वायर काढून त्याच्यात लावायचे.
Yes, sir. Thank you, sir.
Dr. Bishop sir, I would call Dr. Vijay Chale sir, Dr. R.P. Joshi sir, Dr. M.A. Khan sir.
Very precise and हाथ में लगा दो, हाथ लगा दो.
Mr. Sanjay Prasad sir and Mr. Ajay. Dr. Avni ma'am.
थोड़ा सा उधर.
Dr. Jyoti ma'am.
तुझ्या सर्व
Thank you.
Nasim sir, look,
I would like to give you one announcement. So for neuro and spine, if you are sending any patient, our both doctors, they will see high under rupees. For any patient. Consultation charges for any patient, sir will say, seeing that patient only for 500. Thank you, sir.
Nasim sir.
स्लाइड्स का क्या उसी में स्लाइड्स इसमें नहीं इसमें इनपुट हो रहा है ना.
17 नवंबर को लेडीज पिकनिक है. जो लोग भी इंटरेस्टेड हो डॉक्टर अवनी और डॉक्टर रेवती से कांटेक्ट करें. ऑलमोस्ट 50% लोग फुल हो चुके हैं और 50% लोगों की और जरूरत है. 17 नवंबर
17 हेलो 24 नोव्हेंबरला 24th of November we are having ladies week picnic to sorry 24th 17th को उधर शादी है जिधर हम लोग का वेन्यू है, इसलिए हम लोग ने 24th कर दिया है. नहीं ओनली लेडीज विंग पिकनिक है, जैसे हम लोग ने लास्ट ईयर एंजॉय किया था वैसे. इट इज एट नंदनवन रिसोर्ट वैसे ही and bus will be provided free and 1,200 are the charges only for ladies. Those who want to send their ladies and enjoy themselves at home, they can do that.
Next lecture is by Dr. Vani Kulhali. Her topic is anxiety and depression disorder.
सर बैठिए.
मैडम
Vani Kulhali is MD in psychiatry from the prestigious National Institute of Mental Health and Neurosciences, Bangalore, where she trained from 2000 to 2003. Currently, Dr. Vani Kulhali serves as a senior consultant psychiatrist at Amaha Health Clinic in Bandra and as a consultant psychiatrist at Versova Wellbeing Center. She has a specific interest in child and adolescent psychiatry, demonstrating a deep commitment in the mental health of the younger population. Additionally, focus on women's mental health, addressing the unique challenges and needs in the area. Dr. Kulhali, welcome, doctor.
Two mics. Two mics. देखिए दो माइक है तो
निकलिए
I think they can hear. A very good afternoon. I think I really enjoyed the fascinating videos that my colleague showed before. And today I'm going to take you to a world which is more familiar to you than me. Anxiety and depression disorders are seen more by family physicians and non-psychiatric practitioners than psychiatrists. So actually, the real world experts are all of you, and the theoretical expert is me. So I would also invite you to share your experiences and comments. I come representing my company, Amaha. इसका ये की तरह आगे का how will I okay पीछे का स्लाइड green button ना हाँ so I'll be making a not a brief but a short presentation about anxiety and depression disorders, and whenever I speak to colleagues, children, neighbors, anxiety and depression is like a very common thing. Like a 3-year-old kid one day told me, depression, you know, ko, maushi. Everybody knows. But believe me, anxiety and depression is not such a simple or trivial disorders. In this hall, I bet that 60 to 70% of you have already experienced anxiety, and you would wish anxiety or depression, and you would wish that it never ever happens to you ever again or to anybody. It's a disorder that nobody can see, nobody can palpate, nobody can inspect, nobody can auscultate, but which can completely put your life on full stop. You can't do anything. And some people go into a full stop so badly that they are desirous of ending their lives. This is the story of anxiety and depression. So what are the numbers? Epidemiology wise, the most recent study which was done in India, and another round of this is planned in the next 1 or 2 years, is the National Mental Health Survey, which was conducted by my alma mater, NIMHANS Bangalore. And what they found was that the lifetime prevalence of depression is around 5%, and it is ranging from around 1 to 7%. So it's not a very common disease. Okay, but among certain populations, it is extremely common. And dear friends, we are among that high-risk population because of our lifestyle and our occupation. So the rates of anxiety were around 3%. In psychiatric clinics, we see that the most common, like they say that depression is the common cold of psychiatry. So more than 50% of our patients have depression, and anxiety is present in about 20 to 30%. In non-psychiatric clinics, means all of you are treating about 13 to 20% of your patients are actually having anxiety and depression. And I would really exhort you to go back to your clinics and mindfully see each patient whether they have these symptoms, and you will see that the numbers would match to this. A lot of times, I'll come later how the things happen. So the summary is that anxiety and depression, we are not even talking about schizophrenia, obsessive compulsive disorder, bipolar disorder, which are such romantic disorders that movies are made about it. Nobody is making movies about anxiety and depression. Okay. And anxiety and bipolar disorder, OCD, and all these disorders, doctors are not needed to diagnose them. Patient will tell you, I'm extremely sick, take me to a psychiatrist. Because they are so gross, they are so qualitatively different that frankly no skill is required in diagnosing it. Anybody can diagnose it. What I'm talking about today is something that requires a very good sensitivity, clinical skill. That is anxiety and depression. So it's not a common disorder, but it has a significant prevalence and it has very high pain value to the patient. Because a patient of anxiety or depression, he cannot tell his boss, मेरे को anxiety, depression हो रहा है, छुट्टी दो. वो LinkedIn पे और social media पे ऐसे दिखता है, but common life में नहीं होता है. Okay? No daughter-in-law can tell her mother-in-law, मेरे को depression हुआ है, आज आप pressure cooker लगाओ. This doesn't happen. But these are painful things and something has to be done about it. So that's what I was going to tell you, impact. Now there has been a study done in China on around, the sample size has been about 34,000, and what they have found is that any disorder you take, a medical disorder, they have studied mainly cardiovascular disorders, and they backdated the history, and they found that in most of the cases, the starting point was actually a mental health condition or a stress factor. So the commonest complication of untreated anxiety and depression is medical problems. But what we do, we are treating diabetes, we are treating hypertension, we are treating thyroid disorder. Then first year, we are giving 25 micrograms of Thyronorm. Second year, 50 micrograms. Third year, 100 micrograms, and so on and so forth. But we are not correcting the mental health condition, which is the original problem, originator of all these problems. So anxiety, depression is the starting point. If you want any of your medical problems to be sorted, please sort this first. Daily life, poor quality of life, दिवाली है, खुशी नहीं होता है. नया ड्रेस लिया, मैं अच्छी दिखती हूँ कि घबराहट होती है, एंजाइटी. मैं बहुत फैट हूँ, ड्रेस लेके मैं क्या करूँगी? So the quality of life is very bad in spite of the life being bad. There is no unable to function roles. There is a mother who is so depressed that she is not able to enjoy her child. She will constantly go and tell her teacher, इसको इतने कम मार्क्स क्यों आते हैं? ये ऐसे क्यों बिहेव करता है? इसको ये एक्टिविटी में क्यों आप नहीं लेते? इसको गैदरिंग में हीरो क्यों नहीं बनाते? दिस इज एंजाइटी, डिप्रेशन, ऑल नेगेटिव थिंकिंग. इकोनॉमिक, if a person cannot do their duty, somebody has to be replaced and paid. Okay, so there is two costs. One is loss of their work, and second is payment for the other person who is coming there. Other economic losses are they have to go to the doctor. Psychiatrists are not cheap. Psychiatric medications are very cheap. Psychiatrists are not cheap. Therapists are not cheap. Okay, and if they have not found that there is a mental health problem, they have to suffer it for many years, solving other problems. Acidity problem, this problem, that problem, and they're not getting the solution. These are the economic costs. And social costs. अरे उसको मत बुला किटी पार्टी में, वो सिर्फ अपना पेट का बताती है. उसको बता ही मत कि इस बार हमारा किटी पार्टी 17th को है. उसको बता अगले महीने को किटी पार्टी है. उसका कौन कॉन्स्टिपेशन सुनेगा? This is happening. Patients are telling us that, madam, you know what? I am oversharing. I am going to my friend's house. She tells me samosa le. I am telling her acidity hota hai. She is telling me ye le. I have constipation hota hai. She just stop calling me. is depression. Okay, so there is a social cost. So what is the definition and diagnosis for anxiety and depression? Now, as doctors, I think we should know what is actually anxiety and depression. So I'll give you the ICD-11 criteria for diagnosing. Anxiety and fear-related disorders are characterized by excessive fear and anxiety related to behavior disturbances. For example, now we are hearing that there are hoax calls. 80 hoax calls. आपके plane में bomb रखा है. Okay. So normal person, first day they got extremely scared, But now yesterday itself I had one couple who told me the wife had an anxiety disorder, booked tickets to go to Varanasi. She said, I'm not going to Varanasi. Husband is saying 80 calls आता है. क्या probability है अपने flight में रहेगा? Hoax calls है, जाते हैं ना? So the anxiety is excessive. It is unreasonable. Okay? And how does it affect? There are behavioral disturbances. See, even we get anxiety, na? Like when he was presenting those small things, one of the fears I got was, man, wo phatiya to kya hoga? I mean, it's a blunt instrument, but what if he pokes it and that colloidal cyst ruptures? What will happen? Okay, I'm not a neurosurgeon, but if a neurosurgeon, the first time he must have got that thought, but he must have said, sir hai na, wo sikha denge kaise karne ka. So he is managing his anxiety. But if his anxiety is unmanageable, I've had people who have retired from their medical practice for fear of harming their patients. It is unreasonable, excessive fear with behavioral consequences. They just avoid doing those things that they are scared of. Okay, so then the symptoms. So then there are many sub-classifications which we all have to by heart and give the exam to do our MD psychiatry. So the types are generalized anxiety disorder, panic attacks, panic disorder where there are attacks like heart attack. This is a lovely, economically beneficial thing. Every time there is a panic attack, you check the patient from the tip of their hair to the tip of their toe. Get ECG, rule out everything. Stokes, Adams, syncope, everything. Every time you do it, nothing comes up. It's a panic disorder. Okay? Phobias, patient has irrational fears. Then there are some specific things that patients are scared of. Like there is selective mutism. Some people, they become so frightened in certain areas. Typically children, they stop talking in those areas. So mother will come, इस स्कूल में बात ही नहीं करता है, घर में सिर्फ बात करता है. स्कूल में मुंह ही नहीं खोलता है. That is anxiety, selective mutism. And agoraphobia is fear of going out of the house. So there are many women, one of my patient who was pregnant and had to go for sonography. She didn't go for sonography. क्यों? डर लगता है husband जब काम से आएंगे तब sonography के लिए जाएंगे. So husband working in IT call center, by the time he came back, even doctor used to go home. So sonography is not happening. So what I'm trying to tell you is these patients are not pure agoraphobia. They are pregnant patients with agoraphobia. That's how you will see them in your clinic. With depression, characterized by low mood or loss of pleasure, accompanied by other cognitive, behavioral or neurovegetative symptoms that significantly affect the person's ability to function. Child wanted to go to US for holiday. Father said no. He is feeling sad. That is not depression. Depression means it is a kind of, it's not sadness. It is actually a kind of pain of the mind. बहुत दर्द होता है, बहुत तकलीफ होती है, एंड कुछ भी अच्छा नहीं लगता है. ना कोई उमंग है, ना कोई तरंग है. हाँ, मेरी जिंदगी है क्या? So that is the quality of the depressive mood. So why I'm telling you this is many patients of depression, you ask them, they may be in some corporate job doing very well. ऐसे दिखते हैं, अरे मस्त पार्टी में दारू पी के डांस कर रहा है and all. But that doesn't mean he can't have depression. It's a subjective sensation. We'll have to ask that person, what is happening to you? Are you enjoying your life? And if that is not happening, then you can suspect that there is depression. So depressive disorders are further classified into either they can be a single depressive episode. So as against the study done in India, the study done in New Zealand found that 100% of the population has at least one depressive episode. Everybody goes through depression. depression, other than being a disease, it's also a life experience. But why it doesn't come to us is because depression by its nature is actually self-limiting. It's like all other things. If you go for a marathon, you'll have a sympathetic discharge. You measure the blood pressure, you'll have hypertension. That's not hypertension. It's self-limiting. Similarly, depression can be that kind of thing. So there can be a single depressive episode. Typically, I think most of us would have had it at third MBBS. There can be recurrent depression. Depression happens once, then it comes again. It's like the Olympics every 4 years. Then it becomes like the Commonwealth Games every 3 years. Then every 2 years. Then yearly. Then BCCI takes over. Every month there is one program. Then there can be a bipolar disorder. So there is depression as well as manic episode. Person is very excited, cheerful, and they also has depression. There can also be secondary depressions, which I think are very common in your practice. Patient hears that he has a terminal lung cancer and he goes into a kind of a depressive episode. That's a secondary depression. In diabetes, 20% of the patients have secondary depression. So before they have diabetes, they may not have that kind of thing, but later they have depressions. So what we need to note is, even when we are diagnosing depression, we have to see ki iska severity kya hai, which we will know by how they are functioning, what symptoms are there, chronicity, how long is it going on, how much is the distress, patient को कितनी तकलीफ होती है. Some people are in denial, आनंद, कुछ नहीं होता है, बाबू मोशा है, I am doing fine. Okay. People have dysfunction. So I have people whose family members will come and tell us, कि तीनों सारखी, she's going to doctors, she can't do anything, she's crying all the time. But patient herself says, no, I am quite okay. So there's a lot of dysfunction. So when it is severe, it is chronic, there is a lot of distress and dysfunction, then specialist treatment and long-term treatment is required. A lot of people get upset कि क्यों long-term treatment क्यों लेने का? Brain है ना. So if you want to keep it in working condition, long-term treatment is required. So I'll just present a few cases which have come to me. So this is Mrs. AS, who's a 49-year-old woman. This last week only I saw her. She was in the ICU as she presented with acute breathlessness, palpitations, fearfulness, and a sense of doom. She had 3 similar attacks this year, but this one is the most severe. That's why they put her in the ICU. She's on regular treatment for hypothyroidism with 50 microgram thyronorm since 3 years and suffers from frequent bouts of acidity and gas since at least 10 years, which has increased since 1 year. And in the last 1 year, she also developed sleep disturbance, decreased appetite, irritability, worrying excessively, memory problems, and tearfulness. For this, she has undergone gynecological evaluation. A 49-year-old woman has sleep disturbance, has moodiness. Nobody thinks of depression. Menopause. Menopause है. पहले menopause को वही करो. So she's gone for gynec evaluation. Gynecologist has said there is no symptoms of menopause. अभी है, तुम्हारा inning खत्म नहीं हुआ है. Her doctor has recommended alprazolam 0.25 milligram. So no patient in anybody's practice. I think we have the easiest practice because you all will sift them. Now here there is scope for so much to be done, you know. You can do a complete cardiac evaluation. You can do a complete gastrointestinal evaluation. Memory complaints here. So neural interest, there is mood. Those symptoms are extremely there and they are in the background and recurring. Now, I am not trying to say that she doesn't have a GI problem, that she doesn't have a panic problem, that she cannot have a cardiological problem, because I only told you that if something is mental health, these problems are likely to occur. So with all those things, a mental health due diligence needs to be done. So ICU mein, that's what we have done. ICU mein we have ruled out everything. Because I concede to you that psychiatric disorders, anxiety and depression can kill, but not immediately. All these other disorders, patient को जिंदा होना चाहिए ना बॉस, फिर तुम लोग mental health intervention करेंगे. So I think all those investigations need to be done, and this is what we find, that she has some indications. And later when I explored, I realized that there were some marital issues, children not doing well in school, and there was a lot of stress which was happening. When we planned her counseling sessions, small dose of antidepressants, and patients started feeling a little better and more confident. Any comments? Any this thing? Similar patients do you see?
Yes.
Yeah. It's a very typical kind of patient. So now this person, Mr. ABL, is a 40-year-old married male. He's working in a customer service and had a fall yesterday while riding his motorcycle. Presented with pain and swelling of the right ankle region. Due to difficulties in walking, he was unable to step out of the house. He had a fall, but then he just went and stayed at home until he couldn't come out of the house, and he was not able to sleep the whole night. Very typical history. On examination, he has symptoms of ankle sprain and needs specialist orthopedic management immediately. However, throughout the evaluation, patient repeatedly requests for something to, he's not bothered about his ankle. He's saying, give me something to sleep, give me something to sleep. And he has to be supported through the door, not only due to pain. He's doing some weight bearing, but he's unsteady. He's having tremors. That is why the doctor who saw him knew uske piche kya karan hai. He asked him, what is history of alcohol consumption, which he accepted. But patient said there is no problem as amounts are always small and not troublesome. Now see, what happens is socially, the amount of alcohol you drink or alcohol related problems, we have very common kind of definitions of trouble. Because MBBS में अपने को पता नहीं है ना that alcohol first harms the brain then the liver, but we are taught only about liver. So इसके लिए what happens is, the other thing is, if a person is using alcohol and beating his wife, then only alcohol is a problem. If he is drinking and going and sleeping quietly, alcohol is not a problem. Okay. So, but as a professional, we have to recognize, and I was really much obliged to the earlier doctor to show the picture of the Milky Way. There is a common myth among doctors, among common people, that small amount of alcohol is good for the heart. It is not good for the brain. The thing is that every time you drink alcohol, you tickle some of your cells, neurons. But nothing obviously happens to you because you have a huge bank, as many stars as the Milky Way. But कभी तो होगा ना बॉस, अगर तुम्हारा आमदनी 98 और खर्चा रुपया, तो कभी तुमको वो What was that? आज का कैंसिल. आई एम वेरी सॉरी सर, आप ऑरेंज जूस पी लो. So सॉरी, ये पीछे कैसे जाएगा अभी? हाँ, ओके. तो वो, so what I wanted to suggest through this slide is that when you are in your clinic, सबको पता है यार. See, I mean, don't take this in a wrong way, but पत्थर तो, there's some famous movie dialogue ना, पत्थर तो पत्थर होता है, भगवान की मूर्ति भी हो सकता है और steps भी हो सकता है. So when you are in the clinic, no, you be a doctor and you say don't drink even one drop of alcohol. When you're outside, you tell them, I am not wearing my doctor's hat. Don't look at me.
I would hold.
Yes, sir.
I tell my patients, Ram kahe so kar, Ram kare so na kar.
Exactly. See, this is the discussion I wanted. See, the role of a doctor is very difficult. Because there are not 2 eyes watching us, there are 20,000 eyes watching us. Once I was traveling from Pune to Bombay in that Vista Dome, and I was so thrilled, and I was ordering all fried stuff मिलता है ना, उसमें इतना मस्त रहता है. I was eating all that. And just before Kalyan station, the person sitting next to me said, Madam, आप MD करते थे ना Bangalore में 2000 में? मैंने बोला हाँ, मैं आपका पेशेंट था कभी. I was like यार. So we, yeah. So हमारे बहुत पेशेंट रहते, पेशेंट remembers you. Okay, but so I told him, oh ठीक है अभी, I mean that is whatever. So the official take home message today is no alcohol. Yes. Okay, and second message is don't do LFT and tell him कि LFT थोड़ा impaired है, अल्कोहल कम करो या बंद करो. You tell him directly साइकेट्रिस्ट के पास जाओ, तुमको अल्कोहल का बीमारी हुआ है. Because he will not drink alcohol and ride a motorcycle unless he is not okay. None of us do that. हम लोग पार्टी करते हैं, but we hire a driver ना. अल्कोहल लेके मोटरसाइकिल पे जाता है, and on top of that you are saying I don't have any problem. You are not normal. Head injury का पता नहीं है. So substance abuse is a very 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 common thing. Okay, so अभी और एक क्या हो रहा है ना, we have two problems in substance abuse. Lot of people using गांजा, अरे CBD oil, और अपना तो बॉलीवुड का पूरा वो 2 drops. आयुष मिनिस्ट्री has given license for medical hemp prescription, but I am telling you, my thesis was on cannabis. It can ruin your brain. So official line is no drugs, no psychotropics. And if you are having a tendency to use it despite of knowing this fact, then go and consult somebody. That should be our thing. Third is Mrs. KK, who is a 76-year-old widow residing with her son and his family. She is in remission from leukemia. अभी वो ALL, AML वो सब मत पूछो, मैंने नहीं पूछा उसको. And she is under maintenance regimen. Since the last 4 months, she reports with decreased appetite, easy fatigability, lack of interest in doing activities she enjoyed earlier, decreased appetite resulting in weight loss, and she also has a disturbed sleep and frequent aches and pains and feeling of malaise. बुखार के जैसा. Oncologist has checked, सब PET scan, सब किया, everything is normal, and he has told कि इसको ना कुछ तो है, आप जरा check करवा. But family is not accepting. What is family saying? There are early symptoms of relapse of cancer. So you can put her on some regular monitoring to catch the relapse of cancer. But oncologist is telling there are no cancers. So this is a common problem in our practice, and we are telling the patients कि भाई एक बार check करा. These are symptoms which can be of depression. Get it checked. But if there is some other disorder which is a life-threatening, serious, glamorous, whatever, they will keep pursuing that. Not only the patient. अब बहुत बार हम लोग उनको फिर सोमेटाइजेज बोलते हैं कि इसको टेस्ट करवाओ. They'll change the oncologist. Oncologist has told कि you go, you take this thing. So here I think every doctor will have to learn how to talk to this patient and put them on the track to self care. थोड़ा better होने के बाद patient को खुद को realize होता है कि this is something else, and then they are more open for consultation. Okay, this is Mr. AGN. I think all of IT, and has his own successful business that's doing very well. He has been diabetic since the last 10 years. He is meticulous about his diet, medication, and follows up regularly. Yet his sugars are not completely in control and hovering between 7.5 and 9. He is slightly overweight, has no addictions. AGN's wife corroborates his complete dedication to diabetes care. AGN always comes to follow up with a detailed graph. Engineer है ना, वो graph डाल के आता है. HGT scores plotted against time in different contextual. When I was traveling, मेरा graph ऐसे था. When I was doing office work, graph ऐसे था. AGN spends a lot of time researching and trying new forms of diet and exercise to gain control of his sugars. He carries his food box everywhere and follows meal times to the dot. And if they go for a movie, he will say, "मेरा डब्बा किधर है?" No, and at that time he has to eat, which is very annoying for the wife. But she says, "ठीक है, he's taking care of himself, so I understand." Both AGN and his diabetologist are working really hard. वो AGN का sincerity देख के ना diabetologist is coming under pressure कि यार ये इतना मेहनत कर रहा है, why am I not able to treat him? Means the depression is not only in the patient, now it is coming to the doctor. We all have such patients, na?
Yes. Doctors also.
So who are coming under pressure? So what I'm trying to tell you is chronic disease can change the personality of a person. And this personality change itself, see, if this AGN is so, this thing, now that stress itself will destabilize his diabetes. The answer is he needs to cool down, man, have 2 samosas. That is his treatment. But that the diabetologist cannot explain, because he'll think this diabetologist is going to kill me. He'll go to another diabetologist. So there, मैं अच्छा बता रहा था वो भाग गया.
It depends on how you tell them.
Exactly. Not only that, we will have to tell this person that there is some stress and psychiatrists also treat stress, so go there. That's the shortcut thing. So I have given you some 4 common scenarios which are occurring in every practice and which you are treating, and we can help you to treat. We can't treat them. If you send a diabetes patient to us, we can't treat diabetes. But if we can work on his personality, we can help you to treat. Okay, so this is our commitment to you. How do we do that? There are 3 steps in the treatment. We do education and self-care, medication and psychotherapy. So what do we do in education and self-care? We tell them the explanation of diagnosis. When we tell the patient तुमको डिप्रेशन हुआ, he said कशाचं डिप्रेशन आहे याला, सगळं तर आम्ही देतोय. किस चीज का डिप्रेशन है इसको? क्या बोलते हैं मैडम, आपने तो हमारा इंसल्ट कर दिया, इसको डिप्रेशन है. That's not depression. We have to explain to them that there are certain chemical or certain neurological responses, and one organization called WHO has said कि ये एकत्र आने से उसको डिप्रेशन बोलो. मैं नहीं बोल रही हूँ डिप्रेशन है, बीमारी का नाम डिप्रेशन है. ट्रीटमेंट एक दूसरे से बात करने के लिए वो वर्ड इजी होता है, इसीलिए मैं आपको बोल रही हूँ डिप्रेशन है. आपको किसी चीज की कमी नहीं है, आप खुश हैं, आपका नर्वस सिस्टम में कुछ गड़बड़ी है, उसको सेटिंग करके आओ. ओके, इमीडिएट लाइफ चेंजेस टू बी मेड इंक्लूडिंग टेकिंग रेस्ट. सो डिप्रेशन है तो व्हाट दे डू इज पूरा स्ट्रेस निकालने के लिए घर जाके 9:30 से 11:30 में नेटफ्लिक्स पे बिंज करता हूँ. डिप्रेशन बढ़ जाए. सो यू हैव टू एडवाइस तक कोई भी बीमारी रहेगा उसको आप नींद अच्छा दो, ठीक हो जाता है. कोविड में भी लोग नींद से ही ठीक हुए. एंड देन डिप्रेशन से फॉरएवर अच्छा होने के लिए लाइफस्टाइल मॉडिफिकेशन करना है आपको, in which you have to have a good diet, good attitude towards life. त्याच्याकडे BMW आहे, माझ्याकडे फक्त मर्सिडीज आहे. This is causing depression. So all these things we are talking with the patients.
And exercise.
हो, आजकल exercise. Do things which are good for you. ऐसे मत बोलो कि मैं कुछ भी करूंगा, डॉक्टर आप मेरे को ठीक करो. अरे तुम कार का भी देखो ना, मॉडल बदलना पड़ता है. तुम्हारा ब्रेन का दूसरा मॉडल मैं नहीं दे सकता, मरने तक यही यूज करने का. ओके, वी आर ओनली मेंटेनेंस इंजीनियर्स. तो दिस इज इट. देन वी यूज मेडिसिन्स. See, medications, there was a study, 47% of psychiatric medicines prescribed by this thing. I have no objection, you can do it. But after prescribing and patient is not doing well, best to go to a psychiatrist. What we do is we select a suitable antidepressant. There are 30 antidepressant medications available. We have to match the patient. Age, gender, side effects, medical profile, we'll choose it. Adjunctive medications for sleep, for anxiety, for other parameters. And we set up monitoring plan. अभी वो ठीक हुआ है कैसे पता चलेगा, या उसको साइड इफेक्ट हुआ है कैसे पता चलेगा, तो बाद में वेट गेन हुआ तो. सो ऑल दीज थिंग्स हैव टू बी मॉनिटर्ड.
Written 5 years continuously for 5 years. The patient has
No, my medications to be prescribed by a psychiatrist with 5 years experience. साइकेट्रिस्ट को एक्सपीरियंस होना चाहिए ना. One year, minimum 1 year. Minimum 1 year. So psychotherapy we are recommending. We have a very strong psychotherapy department in Amaha. So this I want you all to hear more. So In some cases, can be the exclusive modality of treatment. Some patients say मला medicine नाही घ्यायचं, फक्त तुम्ही therapy करा. 60 to 70% of the patients can do this. And if you are sending patients at early stage, बहुत सीरियस होने के बाद साइकेट्रिस्ट के पास भेजेंगे तो मेडिसिन लेना पड़ेगा. फर्स्ट स्टेज में भेजेंगे तो ये हो सकता है. Okay, so the sooner you send, the more applicable this is. Therapist. Now there are people doing online 2-week course in counseling and trying to treat. वैसे जन के पास मत भेजो. Therapist should have at least MPhil, 7 years training रहता है उनका, BA, MA, MPhil, and 3 years of experience under supervision. It is as challenging as a medical profession. 10 year उनको ये होना चाहिए, and they themselves should be in therapy. वो सब poison लेते हैं ना, उधर जाके निकालना पड़ता है, and have supervisory oversight. Okay, it is just like our medical this thing. And for uncomplicated cases, it usually takes about 8 months of intensive work. यानी once a week they have to go. आज मेरे को तबीयत ठीक नहीं है, मेरे को एक counseling दो ना. It doesn't work like that. It has to be done every week for 8 months. And for serious cases, it takes 2 to 3 years. Why am I telling you all this? Is because patient will come and tell you, वो पैसे लेने के लिए हर हफ्ते बुलाते हैं, निकालते हैं पैसा. This is not true. It requires that much time. See, not only the protocol. See, if you are doing the physical examination of the patient, आप लोग उसका kidney palpate कर रहे हो. In psychiatry, we have to teach the patient to palpate his own kidney and tell us what is happening. So there is a whole round over there. So what are the problems? I think all of us are here mental health professionals, because we are treating some cases, but majority are treated by you. And all medicine is mental health. ये तो मैंने declare कर दिया है. Okay? But we are telling them everything. But challenges क्या है? One is it is a hidden illness because of lack of training. See, it is not our fault. We are going sincerely to MBBS, medical college. Whatever they are teaching us, we are learning and we are giving exam. अपना curriculum में ही उसको importance नहीं दिया, तो हम लोग क्या करेंगे? And अगर अपने इंटरेस्ट से मेरे को साइकेट्री सीखने का है, तो टाइम किधर है? बायोकेमिस्ट्री में फेल हो जाएगा. So we don't have a choice. Second is sensitivity. See, if you don't see something, you are not sensitive to it. And then you feel, like I remember in my MBBS, I did it from an excellent medical college called BJ Medical College, Pune. But हमारे यहाँ ना 60 नंबर का एक OPD था. उसमें क्या करते थे? GVC. They were all mentally ill patients. General Wake Complaints Clinic. And all the people of depression were just given some random things, and only interns used to sit in that OPD. So this was happening. It's changed now. Hierarchy. Patient has cancer and patient has depression. कैंसर का ट्रीट करो, डिप्रेशन अपने आप ठीक हो जाएगा. ऐसा नहीं होता है, बस दो अलग बीमारी है. So you have to understand that there is no hierarchy in medicine. There should be no. Okay? And misattribution of cause. Patient बार बार आके तुमको बोल रहा है ये हो रहा है वो हो रहा है, क्या न्यूरोटिक है, उसको करने के लिए काम नहीं है. सास उसका सर खाती है, वो आके मेरा सर खाती है. So there is misattribution of cause. Patient acceptance. You are telling the patient is not accepting, क्योंकि स्टिग्मा है ना, सबको पता चल जाएगा मेंटल का पेशेंट है, उसको कैसे लगेगा. So you have to have compassion for this. Accessibility of care. You will tell, अरे परसों मैंने डॉक्टर वानी को सुना, सही डॉक्टर है, बॉलीवुड का भी डायलॉग आता है, तू जा उसके पास. You will give the number. Dr. Vani will not answer the call. She will tell the receptionist. Receptionist will say, आज नहीं, कल आओ, परसों आओ, ये आओ, वो आओ. So the accessibility is very difficult. So in Amaha, one of the things that we have done is we have a website. You can book on it 24 hours a day. And we have 16 psychiatrists. एक नहीं है तो दूसरा मिल जाएगा. ओके, ऑनलाइन ऑफलाइन नहीं तो ऑनलाइन मिल जाएगा, कोई ना कोई मिल जाएगा. ठीक है, वाणी चाहिए तो भी अम्मा. हाँ, थैंक यू मैम. सो एक्सेसिबिलिटी ऑफ केयर एंड स्टिग्मा एंड मिसकंसेप्शन. स्टिग्मा कम्युनिटी में है, हमको सब पता है, बट हम कम्युनिटी के अगेंस्ट नहीं जा सकते. See, we are embedded in the community. We know कि we have to have our position in the community. तो इसके साथ हमको काम करने का है. हमारे जो गुरु है डॉक्टर हरीश शेट्टी, वो बोलते थे कि मैडम हाँ किसने करनी किया होगा, बट करनी का सोल्यूशन मैं दे सकता हूँ ना, ले लो ना.
He was a speaker in our.
Yeah, see, he has done so much work about stigma, and he is a जीवंत example of community में कैसे आपको काम करना है. तो community को धक्का मत दो, fighting मत करो, boxing मत करो, but you should know कि क्या हो रहा है. वो दौरा बांध के आई है डिप्रेशन के लिए, दौरा नहीं निकालने का, ये अंधविश्वास है. क्यों बोलने का, बांधने दो ना उसको दौरा, अपना क्या जाता है, बांध दो दौरा. अच्छा है ना. करेक्ट. सत्यनारायण पूजा करने का करो. सत्यनारायण पूजा करने का करो. शनि सिंगापुर जाने का जाओ. Yes, whatever you want to do. Take treatment. Yeah. So take treatment and please, वसुदैव कुटुंबकम, आप भी अच्छा रहो, हमको भी अच्छा रहे. So I conclude अभी डॉक्टर्स के लिए लाइफ कैसे बन गया है बोलो. In today's world, patients rarely fit into neat categories according to systems described in medical education. Medical education है anatomy, physiology, फिर औरतों का एक डॉक्टर है, यूरोलॉजी का एक डॉक्टर है, ब्रेन का. पेशेंट को कुछ लेना देना नहीं है. He can come in any combination. Modern medical practitioners should work with multimorbidity. So you are working with somebody who has chronic renal failure, plus bipolar disorder, plus diabetes, plus marital discord, and is very poor. जो चाहिए वो very common. And he has not come for that. He has come to you for cold and cough. So we have to work, give relief to patient, not restrict their intervention to solving only immediate and felt concerns. तो उसको खोद के बताना पड़ेगा कि यार तू ये किडनी के लिए वो जो आयरन का पानी पीता है ना, हो जाएगा तेरा खत्म. You'll have to dig out that history. So this is the challenge for us, and this is not my statement. Dr. Norman Sartorius, who is my mentor and who was the previous director of the WHO, he has given us this to all the mental health professionals कि तुम ऐसे काम करना सीखो. तुम स्किज़ोफ्रेनिया पकड़ के मत बैठो. स्किज़ोफ्रेनिया आ जाएगा, चल के आएगा. तुम ये काम करो कि स्किज़ोफ्रेनिया प्रिवेंट करो. ओके, एंड दैट इज व्हाई once we do this, mental health is the basis for a healthy and peaceful society. This is again my faculty, Professor C.R. Chandrasekhar, who was given the Padma Shri for his work. इसका मतलब क्या है, आप जब बाहर जाते हो ना, फर्स्ट थिंग क्या होता है, सब लोग हॉर्न बजा रहे हैं, they are trying to overtake. Why are they doing it? क्योंकि ये स्टेबल नहीं है. All of you are from Bombay. 20 years ago ये हालत नहीं था. रेड सिग्नल सब चुप से खड़े रहते थे. अभी नहीं. The moment there's a red signal, फोन खुलेगा. The moment there's a green signal, because the brain is not stable. And ये फैलता है. वो हॉर्न बजाता है तो मैं हॉर्न बजाती हूँ. So our society's peace has gone. तो where have we come? डॉक्टर्स का जिम्मेदारी कितना बढ़ गया है. एक तो करेक्ट वोटिंग भी करना है. So what I am representing today is Amaha Health, which is a Mind Crescent Ventures ka company, and our founders, Dr. Amit Malik himself is a psychiatrist. He has also done an MBA from London School of Economics. And Neha Kirpal, she had lived experience. उनके फैमिली में कोई लोग थे जो इतना मेंटली इल हो गए थे, वो बच्ची थी तब, तो उन्होंने एक्चुअली देखा है. So these two people thought कि ये सीन हमको थोड़ा चेंज करना चाहिए, because lot of misconceptions are happening. So this company started, and because I agreed with their philosophy, I have joined them. We have a lot of diagnosis, group intervention, awareness building campaigns, personalized self care. आप हमारे वेबसाइट पे आएंगे, हमको ₹1 देने की जरूरत नहीं. You can download lot of tools for self help. anxiety tools, ADHD tools. Don't give us even 1 rupee. So treat yourself. जो मैंने बोला था ना कि who have not gone to that level, उनके लिए services है. So there's a 360-degree support. And we have 3 clinics now, New Delhi, Mumbai and Bangalore. And in Bangalore, we are shortly coming with a hospital, inpatient hospital. So that is it.
पहले मुझे पूछा कि मुझे लगता है डॉग शॉर्ट करना पड़ेगा, तो मैं बोला हाँ मैं लेट हो रहा है, तो मैंने बोला 30 मिनट्स का है 20 मिनट कर देंगे, तो मैं बोला ठीक है, लेकिन 50 मिनट्स कैसे चलेगा पता ही नहीं चला। फिर एक बार क्लास मैडम के लिए थैंक यू वेरी मच।
I just wanted to ask you one question. These anxiety patients, they stop the medications in between. So, what can we do in that case? लेकिन हाँ अभी हम ठीक है, why should I take the medication?
Don't get upset. Don't get upset. Educate them that how you stop the medicine. If you're okay, there is no problem. But if you get any few symptoms, immediately you come. Don't get upset.
Hello, Felicitated Dr. Vani Kulhali ma'am. I would like to call Dr. Revati Singh.
Sir says that some patients are not affording. उनके लिए हम लोग क्या solution दे सकते हैं? इसमें 2 कैटेगरीज है. बहुत सीवियर रहेंगे तो सर उनको भेज दो. माइल्ड और मॉडरेट रहेगा ना, तो योगा इज रिकमेंडेड बाय हार्वर्ड मेडिकल स्कूल, by NIMHANS, by NHS as a treatment for anxiety and depression, and free yoga training is available on NIMHANS website. Every day 6:30 morning live stream होता है वहाँ से. आप NIMHANS का ये करो, or you can send them to train yoga. Get trained in yoga. The good yoga schools in Bombay are Yoga Institute Santa Cruz. Hot yoga and power yoga से ठीक नहीं होता है. It has to be a mindful yoga. So yoga. Okay?
मेडिसिन में क्या दे सकते हैं?
मेडिसिन में सर शॉर्ट टर्म आप कुछ रहेगा ना, मेलेटोनिन दे सकते हैं, एंजियोलाइटिक दे सकते हैं,
एमिट्रिप्टिलिन
दे सकते हैं. एमिट्रिप्टिलिन थोड़ा साइड इफेक्ट ज्यादा है, लो डोज दे सकते हैं.
आदित्य मैडम
रेसल्पिडल का क्या?
हाँ?
रेसल्पिडल
डॉक्टर अदिति राज.
कौन दे रहे? हमका फोटो.
डॉक्टर रमेश जैन सर, डॉक्टर अवनी मैम, now I would like to call Mr. Vinayak Soni and Mr. Ashish Rana
Please cover the station.
to felicitate them. Dr. Rajesh Kokani sir. Thank you, Amma and my recent wellness venture.
I just want to appreciate the Vani. Sympathy for your patients. Everybody please listen for your patient. There is a card here, and if you are going to refer the patient with that card, you will get 30% 40% discount on this consultation. Please collect the part from the registration center. Thank you so much, everyone. And second thing, our annual conference, who are not registered, please listen, who are not registered for the annual conference, this year we are going to give 2,000 costing smartwatch to everyone. So please get registered yourself. We are not having that much seats. Already 125 seats are booked. Hardly we are having 100 seats. So please get yourself registered already. Thank you so much, everyone.